Hello, my name is Dr. Jay Granzow, and I'm honored to be invited to present a brief overview of lymphedema surgery. I've been doing lymphedema surgery for over 15 years, and it's really a topic about which I'm very excited, and I would love to share my experience. What's most important is that this is a team effort, and I can't do this without all the hard work and dedication of everyone that goes into taking care of the patients on our end. That includes Amy, Julie, Kat, Tao, Jerica, Sharon, Helen, Alexa, and Aaron, and the rest of our team in our office and our hospitals. Thank you very much. In addition, I thank, again, my family for letting me have the time to be able to come here and put this talk together to share our experience with you. This is at a fundraiser for my daughter's special needs school, and certainly I thank them also because they're so important. Overall, generally, lymphedema surgeries, as they're seen, I think, as they're generally appreciated, are seen as separate from lymphedema therapy. So I think many people see lymphedema non-surgical treatments and therapy and compression on one side of a line, and the lymphedema surgeries on the other. Surgeries tend to be broken down into a reductive surgery, or something that gets the solid excess, and microsurgery and supermicrosurgery, which tends to perform lymphatic reconstruction to help the drainage. But I think that's a mistake. I think that for me, I don't want to have a red line between the therapy portion and the surgery part. I think it's very important to have them integrated together in one system. Now, these are my opinions, and different surgeons will provide different views and recommendations according to their training and experience. So for me, the three main modern surgeries that I perform are SAPL surgery, which is the reductive component. And what we do is we take all the excess fat and proteins that have accumulated in late stage disease, and we're able to remove those in a very safe and consistent fashion. The VLNT, which is the vascularized lymph node transfer, and the LVA surgeries, those are microsurgeries that are the reconstructive portion to help improve the drainage. For me, it was important to put everything together, so I assembled the first comprehensive system to actually put the microsurgery and the SAPL surgery together in one system, with the key glue being the therapy component. The therapy component is absolutely critical. I feel that without proper therapy evaluation and a good plan with the therapist before surgery and afterwards, I think we won't get the results that we can otherwise achieve. And the patient selection is critical. Sometimes these surgeries, or at least in many cases, these surgeries can be combined in a way that they're performed as, for example, one set of surgeries like a reduction, then we wait for healing to occur and we perform the reconstructive portions afterwards. This is a patient who's a very typical patient we might see, who has this solid late stage 2 presentation of lymphedema in the right arm after breast cancer. And this is what we would expect as a typical result, meaning that the arm ends up about the size of the opposite arm, and the compression garment use is dropped significantly to where she can go out during the day and not have to wear the garment or sleeves as a regular expectation. Each patient will have a slightly different result depending upon their own issue, their lymphatic system, how much damage they present with. But overall, I think that's a very realistic result. So what can we accomplish? We can, typically surgery can produce reproducible significant improvements, both in volume, meaning can we get the patients back to wearing regular clothes and shopping in the regular clothes section? I think that's very realistic. And can we improve quality of life significantly? I think that's very realistic. Our volume excess, and we talk in cc's or volumes, our reductions on average, in our experience, are 86 to 111% average. If the volume reduction is over 100%, that means that that treated arm is actually smaller when we're done than the unaffected side, arm or leg. And our infection rate drops tremendously from an overall average of about 58% to 15%. This is a massive improvement in the patient's health. We significantly improve the lymphedema therapy effectiveness and also the effectiveness of the compression garment use. Now, to understand this, the way I conceptualize a very complicated disease process, which is lymphedema, is that there's a lymphatic circulation which is somehow interrupted, which causes a buildup of the toxic inflammatory lymphatic fluid. This at first causes a fluid predominant swelling, which is called stage 1 lymphedema. Now, if this fluid is allowed to sit, it causes permanent damage to the surrounding structures and eventually causes additional deposits of fats and proteins, which can no longer be removed with conservative therapy or compression. This is called stage 2 lymphedema. Stage 1 can be treated with conservative therapies such as compression, lymphedema therapy, and the microsurgery reconstructions. Stage 2 cannot. For that, we need sample surgery to remove those solids and get us back down to a stage 1. This is a very typical presentation of a patient with stage 2 lymphedema on the left side. This is how an MRI scan might look. And this is a section, different patient, but same idea of but both of these are from the same patient of the normal side here. And there's muscle, that's the gray underneath with the normal thickness of the skin and fat and soft tissues. And this is the affected side, which is much, much larger. Those solids, especially the gray material, cannot be treated with a microsurgery technique or a conservative technique and need to be suctioned out and aspirated very specifically. And you'll hear more about that in other lectures as well. So again, I call this procedure a SAPL procedure, suction-assisted protein lipectomy. The patients have lymphatic systems that are already severely damaged, and the arm or leg never reduces in size to match the opposite side. Now, this is not cosmetic liposuction. I hear the word, we know that the word liposuction has been used by some, and outside North America, I think that makes more sense, but it is not cosmetic liposuction. The cannulas we use are different. The cosmetic ones will not work on the solids that are there. The therapy is entirely different. The planning is different. The volumes we get out are much higher. The patients have overnight stays because this is a complicated surgery that really takes a lot of care and effort, far and above and in a different way than cosmetic liposuction. Here's a patient example. So these are hard patients. Patient with chronic edema, 19 years. The right arm never goes down to match the opposite left side. She's having so many infections from the inflammation that she requires prophylactic antibiotics. And she has almost 900 cc's of volume excess. After 6 months, and this is a pretty typical result, the arm is already coming down in volume. And at 18 months, it's coming down. Now notice that she has been wearing a compression garment before surgery and after. We don't add the need for a compression garment afterwards, but we maintain that. And they do maintain the garment because we haven't done the reconstructive part yet. So they stay down and the patients do much better following this type of a surgery. And you'll hear more about that later. Again, this is not cosmetic liposuction for a number of different reasons that I've just gone over. The canister and the aspirate that we get out are often quite different as well. So this is cosmetic liposuction, and this curdled milk looking canister on the right is more of a lymphedema fat and protein type of aspirate. The volumes that we get out are also quite different. Patients with congenital lymphedema and secondary lymphedema, at least in my experience, seem to do just as well when they're being treated for the stage 2 disease to get them back to the stage 1 disease. Sample surgery is also safe. We find that the lymphatics are not damaged, and this has been repeatedly shown in the literature. Back almost over 20 years ago by Dr. Brorson as the first one, and we can perform imaging before and after to show that. This is imaging that's worse before, it tends to improve a little bit, but we have not seen it get any worse in any of our patients. Now, on the reconstructive side, for either an early disease or a patient that's been previously treated with SAPL surgery to get them back down to a stage 1 issue, we can perform microsurgery as well. 2 types of microsurgery: VLNT, which is vascularized lymph node transfer, and LVA, which is lymphaticovenous anastomosis. Key point here is that these will not be effective in treating late stage 2 disease because they cannot remove the solid. The patients in late stage 2 disease have some fluid present, so if this procedure is performed in a patient like that, it will make them feel better. It will make the volume come down a little bit, but overall that inflammation is still present. Those inflammatory tissues will continue to cause progression of the disease. In my experience, these types of connections tend to fail further over time if performed in a late stage patient that still has a lot of inflammation present, and then you can't use those sites in the future for reconstruction. The techniques are quite technically demanding. The procedures require a high-powered microscope with very fine suture. These are examples of some sutures that a slide that I took with made with Dr. Kashima a long time ago. And there's a lymphatic needle, a regular microsurgery needle, and a fine hair, which happens to be my hair there, and a ballpoint pen for size comparison. Lymph node transfer. Most people have heard of this. We transfer lymph nodes from one part of the body where there are excess to another part of the body where there aren't as many lymph nodes present. Different ways of doing this, different donor sites have been described. These are just a few. One is from the groin area. Key being that we do not take from the portion of the lymph node basin that drains the adjacent leg. We can perform a technique called reverse lymphatic mapping, which I always perform to make sure that we absolutely minimize that risk. And we haven't had an issue with that. And I haven't heard of a colleague who's had an issue with with donor site issue with reverse mapping. This can come from the torso as well if we need to take them down to the leg. Again, avoiding those lymph nodes in the armpit or axilla. And we can take them with a breast reconstruction flap. People describe omentum in other areas as donor sites as well. Again, keeping in mind that different surgeons have different techniques. So this is a picture from a paper published, work done elsewhere. And the lymph node transfer is actually put down towards the ankle. We can see the skin grafts that are required to help treat this from the thigh above. Those are those pink areas, perhaps little grafts, vein grafts with the little lines there. Just technically, I do them differently. I don't, for a number of technical reasons, I do not like to put them distal, meaning down at the ankle. I like to put them up at the thigh. And so this is where we tend to put them. That patient has had a lymph node transfer there to maintain her volume improvement on that side after a SAPL surgery. And garments can be used better. The appearance is better. So those are the reasons that I personally use them. Again, different surgeons have different methods. And these are long-standing results. So this is a patient, the very first patient I took care of. She was a Los Angeles police officer, and we wanted to get her back to work. She had tremendous swelling in her arm, but fortunately it was stage 1. I did a lymph node transfer. She's well over 10 years out with no recurrence and a fantastic result. And she actually doesn't require a garment to keep her lymphedema down. Otherwise, we can consider LVA surgery. That's where we actually find the small lymphatic channels themselves. These are usually 0.1 to 0.9 millimeters in diameter. We know they're blocked somewhere upstream, and so we divide those and plug them into veins with one-way valves so that the lymph flow can go straight to the venous system and get that lymphatic fluid back to the veins where it belongs and out of those soft tissues. Technically, these are extremely complex because they're so small, but we can see that these can be done consistently. Here's a lymphatic that I've attached to a vein. There's blue dye that we can have the lymphatics take up, and we can see that dye flow into the vein very consistently. This is me with Dr. Kashima in 2005. Again, give credit to him for developing this technique in the peripheral area, just like Dr. Brorson developed the main technique for on which we base the SAPL surgery, and we really thank them for absolutely their wonderful contributions here. For LVAs, we do ICG imaging to help us guide our incisions. This is me mapping out a patient in the operating room, and we use the laser and the specialized dye imaging to make our surgery quicker and more efficient. Here are the connections. The arrow points to the connection of the lymphatic to the vein. On the right, you can see a needle that is present with a fine suture. And that stick is actually a small surgical suture I use as a size reference here. So we can see that that's a 1 millimeter mark. And this is probably 0.5, 0.6 millimeters in diameter. These procedures also work long-term. This is a patient where we had a 55-month follow-up. The volume doesn't reduce that much because it's already reduced. But what you don't see is that the patient's therapy went down tremendously. Her garment need went down tremendously, and her ability to do things not wrapped up in her lymphedema self-care day-to-day went up tremendously. Here's another patient, again, the ankle. You can see that it's very hard to show on a picture how much improvement they get, but the results, even clinically, are significant and tremendous. Here, her ankle and foot were feeling much better. And we sometimes get images afterwards. And here we can actually see how those lymphatics have recovered after the LVA surgeries in this particular patient. Again, we're not looking for the large volume decreases as we see with SAPL surgery. And so we have to measure these in different ways. For example, the garment requirement before and after surgery decreases tremendously after an LVA or VONT surgery when properly performed in the right patient, as does the therapy requirement. So we still absolutely insist that the patients maintain that therapy relationship with their therapist, but what the therapist does is more effective, works better, and everyone does better overall. Finally, I'll wrap up with the possibility of a two-phase method. If there is a patient with a stage 2 chronic lymphedema, we can reduce that volume, bring that arm or leg down to a normal size, and then let it heal, and then come back with the microsurgery and get them out of those garments more, and we can get them more reconstructed so we can have our proverbial cake and eat it too. We can really decrease the size and improve the function when done properly. We're collecting more data with this, but a lymphedema life impact score or scale is an indicator of how much better the quality of life becomes. And we see absolutely tremendous improvements in this scale, both before and after the phase 1 SAPL surgery and before and after the phase 2 microsurgery as well. With a special shout out to Erin McGinnity, who was really working quite hard and helping us put together all of the data points that we've collected in many patients over the years. This is just a sample of only some of the patients that we've taken care of. We've published this one as well in the literature. Thank you very much.
I am Håkan Brorson. I will talk about modern debulking techniques for lymphedema and lipedema. I will show step by step how we can manage these patients with leg and arm lymphedema. So why do we do liposuction? Here you can see excess adipose in the right arm on a patient with severe arm lymphedema. This is the first MRI we did on a patient with arm lymphedema. You can see the excess adipose tissue in the upper arm. Here's a typical aspirate from 2 patients with almost 100% fat in both canisters. This patient has a deep pitting, and this patient has no pitting. So this is a combination of lymph and fat, and this is only fat. Here we go for conservative treatment, and in this case, liposuction is a good alternative. So what is the problem in non-pitting lymphedema? Well, the problem is fat, not the lymph. Because lymph can be easily removed by conservative treatment, but the fat needs to be removed surgically. Adipose tissue in non-pitting lymphedema is a question of medical ignorance. Here are a few citations I've heard through the years. Adipose tissue, I've never seen it. It says something peculiar for Swedes. I don't see any adipose tissue. Maybe Swedes eat different food than the Mediterranean people, and that liposuction is science fiction. So is there then any evidence for adipose tissue hypertrophy in lymphedema? We did in 11 patients volume rendering computed tomography, which we have published. And here you can see to the left the right lymphedematous arm, and to the right the left arm. And then you can tell the computer just show pixels for fat. And in this case, there was an excess fat volume of 1.3 liters. We also continued with the dual emission X-ray absorbed geometry in 18 patients. And here we can have regions of interest and exactly calculate the amount of muscle, fat, and bone. And here you can see that the lymphedematous arms in this series were 58% larger than the normal arm. They had 73% more adipose tissue and also 47% excess muscle tissue due to the heaviness of the arm. And also due to the heaviness, there was also an increased bone mineral content. You might think that the duration of lymphedema parallels the amount of adipose tissue, but there is no such correlation. So I ran across this paper from Schneider and colleagues. Here you can see to the left the wild-type mouse. Lymph leaks out from the blood vessels and everything works fine. It's drained through the lymphatics. In the mutated POX1 mouse with deficient lymphatics, the lymph is not absorbed, so lymph stimulates fat cells differentiation and growth from fat cell precursors to fat cells. And here you can see the mutated POX1 mouse on the upper part and the normal wild-type mouse. And the team behind Geoffrey Gertner showed that the underlying pathophysiology of lymphedema drives adipose-derived stem cells towards adipogenic differentiation. So inflammation upregulated genes leads to excess fat deposition, and the goal is to remove the excess fat to get a complete reduction with the help of liposuction. So here's the algorithm. You have an untreated lymphedema, which is about 50% fat and 50% lymph. Then you do the conservative treatment to get rid of the fluid, to a non-pitting edema. You do the liposuction in order to get a complete reduction. So a few examples, pre-op and post-op picture, 3.1 liter, 4.2 liters 1 month later, 3 months later, and at 1 year complete reduction. Now the patient, 3.6 liters 2 years after, slight overcorrection, and 2.5 liters 5 years later. And finally, this patient, 2.2 liters 20 years later. This patient can now start playing golf again because before she could not take out the swing. So here are the patients that we have followed. And you can see we have followed 7 patients for 25 years. And we measure with water plethysmography. We have an excess volume of around 1.5 liters. And here are the results. So around 6 months, we have a complete reduction, which stays there during the follow-up time of 25 years. The candidates for liposuction are slightly different from those for cosmetic liposuction. To the left, you can see my arm pinching an area that has been treated with liposuction, and to the right is an area that will be treated. And here you can see the dramatic effect of liposuction on the distal part of the forearm. This takes about 2 hours, and then we put on a compression garment that we have taken measurements 2 weeks before. This is how it should look like after liposuction. The 10 ways to control edema. Write it down. It should be like a tattoo, never being removed. Actually, our patients remove the garment in the morning, take a shower, and lubricate the skin and take on a clean new garment. And the used garment is washed to be used the next day. So if an edema increases due to ineffective garment or decreased patient compliance. The key to success is information. You have a mental contract of wearing the garments, and you have to have money for compression garments and also follow up if you want to get a good outcome. So we have a simple classification. You do the pitting test, and if there is a pitting, the problem is lymph, and if there is no pitting, the problem is adipose tissue. So conservative treatment is performed in order to get rid of the fluid, and if the arm and leg are still large and no pitting, liposuction is a good alternative. We've been doing this since 1998 and endorsed by the Swedish National Board of Health and Welfare. We also have a National Lymphedema Treatment Program and also national guidelines for breast cancer treatment. A few comments about lipedema. Here's a typical lipedema with sparing of feet. And this patient I operated in Boston. This is before surgery. She had a normal BMI, and this is also on the operating table. And the skin is very thin. And here is the aspirate, 1.4 liter from each lower leg. And this is after surgery. Before and a few weeks later, the preoperative lymphoscintigraphy was normal, and the postoperative lymphoscintigraphy was also normal. Here you can see the excess adipose tissue in the lower legs before surgery, and there is a remarkable reduction after. So the patient had a BMI of 22.7, and during the following years she gained 9 kilograms, but the result is still good. These are frontal pictures. There are various stages of lipedema. This patient also had liposuction of the upper arms due to lipedema. This is after. A few cases before and after. I never operate patients with lipedema with a BMI over 30. Before and after. Before and after. Before and after in the same patient. So little about leg lymphedema. This is what was done in the 50s and 60s when skin and subcutaneous fat was removed down to the muscle fascia. It's called Charles procedure. The problem was that the skin grafts sometimes broke down, and you have a oozing of lymph and a lot of infections. Up to date, we have operated on 126 patients, 64 primary, 62 secondary, and mainly women. All had had conservative treatment before, all used compression garments, and there was no minimal pitting. So here's a follow-up. We have followed 9 patients for 15 years. And we measure volumes with water plethysmography, and the excess volume mean is 3.9 liters. And here is the outcome. It takes a little longer time to get complete reduction, but around 1.5 years we have a complete reduction. This is a small video showing how we do. We exsanguinate the leg. We do this with a tourniquet. And here you can see we start distally and go proximal. 2 days after liposuction, the garment is removed, and you can see there are no hematomas or sagulations. This is the same patient before and after liposuction. This patient had a lymphedema of 14 liters from here to here, 20 years, no recurrence. He can wear any clothing he wants. If from here to here, no surgery, just conservative treatment to get rid of fluid, and this is after liposuction. This is the MRI before surgery, and this is after. You can see the reduction of the adipose tissue. Frontal pictures before and after. 26 liters from here to here. Conservative treatment and then liposuction 3 years later, 4 years later, slight overcorrection. From here to here, conservative treatment, then liposuction with a complete reduction. This patient had almost 5 liters. 2 years later, she can wear any clothing she wants. 6.6 liters, 2 years after, she can wear any clothing. 10 years later, no recurrence. We use various components of compression. Legs, we always have 2 garments, daytime, and 1 garment, nighttime, flat knitted. But this is beyond the scope of this presentation. Before, 7 liters excess volume. 6 months later, complete reduction. Before and after, she can now run 10 kilometers 3 times a week, and she's back to normal work. What about microsurgery? Lymphedema leads to dilatation and sclerosis of the lymph vessels, and microsurgery does not work. So you get valvular insufficiency. This patient was operated in 2012 with microsurgery at the Barcelona West meeting. This is after microvascular surgery. This is what was done. She had a lymphatic free flap and 2 LVAs. This is after microsurgery. There was an increase of 655 milliliters. And then I was asked to do liposuction because microsurgery had no effect. So this is before and after liposuction. We removed 4 liters. And you can see there is increase before liposuction. And after liposuction, there is a steep decrease. And I saw her 3 years after with a complete reduction. These are pictures here, before and after, slight overcorrection. This patient I operated at Macquarie University in Sydney together with Dr. Thomas Lamb and his team. She could not walk these 8 steps due to the big leg. We removed a lot. This is 3 months after, 3.5 years after. She sent this video.
Hi Håkan, Chen, and I'm here at the top of Sydney Harbour Bridge, 1,390 steps, 3 months.
So in conclusion, adipose tissue dominates not predicting lymphedema, and the deposition starts when the lymphedema starts. We have no recurrence. So excess adipose tissue can be removed by liposuction, but not with other means. So the outcome of conservative therapy and microsurgery is limited to the presence of the adipose tissue. This is teamwork. Without Karin to the left and Barbara to the right, we would not reach these good results. We have had 48 teams from all around the world. Here's Team Brorson, Aaron Green and Jane Lim, Jome Masia, Drew Singal, John Boyash and Thomas Lamb, Jake Granzow and Alex Manok, Roman Skoratsky and Holger Engel, Andrei Schuba and Marek Paul. This patient was very happy too. So I thank you very much for your attention, and you can find more information here. Thank you very much for listening to me.
Hello everyone, this is Chen from Cleveland Clinic. Hope you're all doing well out there. It's great to be here. Today I'm going to talk to you about how the way I practice lymphedema surgery has evolved over time as we found out more about lymphedema through lymphedema research. I have no disclosure. Cars evolve over time as technology improves, styling improved, the functions of the cars improved, and so did the performance. And that should be no different when it comes to surgery. This is what my lymphedema surgery algorithm used to look like. I would perform lympha, or the preventive LVA for stage 0 disease, LVA for early fluid predominant disease, lymph vessel transfer for late fluid predominant disease and lymph node transfer for those patients not treatable with lymph vessel transfer, and then liposuction for solid predominant disease, and finally the Charles procedure or radical excision for fulminant disease. This is what my algorithm looks like today. Notice that how the indication for LVA has greatly expanded, and also the lymph node transfer is gone. We no longer perform lymph node transfer since 2017, and the LVA's indication has become expanded because we realized that LVA is still effective in late fluid predominant disease or severe lymphatic injury. And also notice that the liposuction indication for liposuction has greatly expanded, and this really cannibalized on the indication of lymph vessel transfer. So we're now performing a lot less lymph vessel transfer, and also the immediate lymphatic reconstruction instead of the classic lympha, we call it the distally based delayed immediate lymphatic reconstruction, is now routinely performed to prevent symptomatic lymphedema. So I'm going to quickly go over how we perform therapeutic LVA, preventive LVA or DD-LVA, and liposuction, and then we will talk about the recent updates. So starting with the LVA, now I think everybody's familiar with the concept. LVA involves connecting lymph channels to superficial venules. And we use various technologies to map out the location of the lymph channels and veins. In the earlier days, it's mostly ICG and identifying the lymph channels and using infrared to identify the veins. Now we also use duplex ultrasound. But once you have everything identified, then you can strategically plan your incision and make the connections. Of course, the surgeon should become savvy with super microsurgery. In the interest of time, I'm going to play this video very rapidly. This is a demonstration of end to side anastomosis. 0.3 millimeter lymph channel going to a 0.9 millimeter vein. And here's the completion of the anastomosis. And there are various ways to connect the lymph channels and the veins together. We won't go into that in this talk. Just know that surgeons should be versatile with all types of anastomotic configurations, and so the surgeon can adapt to the situations. And the end result is we want to create multiple LVAs on multiple lymph channels at multiple levels of the lymph. Now, immediate lymphatic reconstruction, frequently known as lympha. This is a procedure that's performed to treat lymphedema or to prevent symptomatic lymphedema. So this is performed for stage 0 disease, which is defined as lymphatic injury without symptoms. So, for example, at the time of axillary lymph node dissection for breast cancer, the patient sustained a lymphatic injury, and the classic lympha is performed at the time of lymphatic injury. We propose to perform the surgery after the injury and before the patient becoming symptomatic, because what's the rush? Lymphedema doesn't develop overnight. So you can certainly perform the surgery a week later, 2 weeks later, and the surgery is very easy. The technique is the same as therapeutic LVA. It's 1 or 2 incision, and we call it distally based because we want to move out of the zone of radiation or the radiation field, and therefore our LVAs won't be damaged by the radiation. In this case, we perform it at the elbow. Surgery usually takes less than an hour. It's outpatient procedure. It can be performed under local anesthesia successfully with minimal discomfort to the patient, and in our experience, it's highly successful. Lymph vessel transplant, we consider it the lymph vessel transplant being the lymph node transplant 2.0. And in our experience, it really works the same way as lymph node transfer, and therefore we have completely stopped performing lymph node transfer. And if you just look at how they look, I think which one we should go with is quite clear, as lymph node transfer, in our opinion, is quite disfiguring. Our lymph vessel transfer techniques involve doing ultra-thin skid flap or TDAP flap, just stay superficial to the superficial plane, and you will be able to spare the lymph nodes and only harvesting functioning lymph channels. And then you simply perform the free tissue transfer of these ultra-thin flap. Here you can see under ICG technology, the flap carries high density of lymph channels, and the transfer doesn't create contour deformity because it's an ultra-thin flap. Liposuction. So we all know that lymphedema isn't just fluid edema, it's also lipodystrophy. And therefore, when there is a significant enough of lymphedema-induced lipodystrophy, liposuction should be performed. And the way we do it is with the flying squirrel liposuction, which combines liposuction with excision of skin excess. And this is what we call a positive flying squirrel sign, which is defined as 4 centimeters of skin excess under strong traction from the deep fascia. And we perform the skin reduction, and that significantly improves the contour as well as decreasing dead space and decrease the risk of seroma and hematoma as well as skin necrosis. And this is some of the results. And even a patient like this that we traditionally would perform the Charles procedure, we can successfully treat with the flying squirrel technique. Another patient and another patient on the table result, going from having a bulky arm to a skinny arm, another bulky arm becoming a skinny arm. So here are the updates. Mostly has to do with how we perform these procedures and when to perform these procedures. Update number 1 is we found out that LVA is effective even in advanced disease, even with advanced lymphedema. And we learned this from cases in which we had to convert lymph vessel transfer to LVA. So we proposed to the patient to move forward with lymph vessel transfer, and for various reasons we had to convert to LVA, sometimes due to insurance coverage, sometimes due to patient's preference, and sometimes to our dismay, we found out during the surgery that the patient didn't have adequate anatomy to support a lymph vessel transfer, such as the patient didn't have sufficient venous drainage to support the transfer. So out of a total of 26 cases that we found in the past 2 years that we had to convert to LVA, and we were successful in performing LVA, and patient experienced successful outcome in all 26 cases. So that prompted the question of why did we choose the lymph vessel transfer to begin with? If these patients that we thought needed lymph vessel transfer later on turn out to be successfully treated with LVA, maybe we should just offer LVA, which is a much less invasive procedure. And we found out that through this experience, absence of linear pattern on ICG study and the presence of diffuse pattern are no longer contraindication to LVA. So as I said, the question is, when do we perform the lymph vessel transfer? I don't have the answer to this question. It's a question that we're actively looking into right now. Update number 2, continuing from what I just said, the absence of linear pattern and the presence of diffuse pattern on ICG lymphography are no longer contraindication to LVA, and therefore they're also no longer solid indications to perform lymph vessel transfer. So indications for lymph vessel transfer have become unclear. And what we have found out is that when the patients are offered both LVA and lymph vessel transfer treatment options, all patients will go with LVA. Who wouldn't? Because LVA is much less invasive. So another fruit for thought is, if indication for lymph vessel transfer has become vague, what about lymph node transfer? When would you perform a lymph node transfer? If the patients can be treated with LVA, when would you perform a lymph node transfer, which is a procedure even more invasive and potentially having a higher risk of causing donor-site lymphedema than lymph vessel transfer? Well, no answer to this question yet, and we should continue to investigate. Update number 3, we know that neither LVA nor lymph vessel transfer nor lymph node transfer would treat lymphedema-induced fat deposits or lipodystrophy. So when there is sufficient amount of lymphedema-induced lipodystrophy, liposuction is the treatment of choice. So we no longer look for the so-called solid predominant lymphedema as indication for liposuction. If there's clinically significant enough of lipodystrophy, if there's enough fatty tissue around that bothers the patient, we offer liposuction. And believe it or not, we have learned through our experience, for those ladies with a fatty ankle, even with successful LVA and lymph vessel transfer, that their symptoms were greatly reduced, they were still not happy if their ankles remained fatty. So liposuction in those scenarios would be the treatment of choice. Update number 4. Liposuction can be combined synergistically with LVA or lymph vessel transfer, either in the same anatomic region or in separate anatomic region. And when you combine these procedures, the outcomes are significantly superior to either procedure alone. And when lipodystrophy is isolated in an anatomic segment, for example, in the upper arm, the patient can receive liposuction in the upper arm and perform LVA or lymph vessel transfer in the forearm. And the results the two procedures will work synergistically for leading to a superior outcome. And even when performed in the same anatomic segment, it's still technically possible, although I still do recommend performing liposuction first, so debulking first, and then reconstruction later after more than 6 months to allow for scar relaxation. It's still possible to perform LVA. I think previously many thought this would not be possible. We've learned from experience it's certainly possible, and we are routinely performing that sequence. Lastly, looks like I'm running out of time. DD-LVA, or the preventive LVA, distally based delayed LVA, is now routinely offered to prevent acquired lymphatic injury from becoming symptomatic. And as I mentioned before, this procedure has been highly successful at preventing symptomatic lymphedema. And this can be performed either at the elbow for the arm and knee for the leg. And the procedure takes about less than an hour to complete outpatient procedure. And we perform the procedure after lymph node dissection and before or after radiation. That's all I have. Thank you for your attention. This is Wei Chen from Cleveland Clinic. I'm happy to take any questions now.
Hi, my name is Dr. Jay Granzow, and I'll be reviewing briefly the importance of lymphedema therapy and patient selection in lymphedema surgery. These are two absolutely key points that are critical in making sure that we can produce the best outcomes consistently in our patients that have lymphedema surgery. For me, everything begins by correctly matching the patient's unique condition, and every patient is unique, to the appropriate surgery so that the right patient gets the right surgery at the right time with an integrated therapy approach, because the therapy is absolutely critical to not only making sure that the patient is prepped and set for the surgery, but does achieve the best post-operative outcome. I think this is often overlooked when lectures for surgery are done, or even the thought process for surgery is done, because the therapy is such a critical point. First, all lymphedema patients are unique. These are two breast cancer patients who had lymphedema following breast cancer. The one on the left is a stage 1. The other one is a stage 2. The stage 2 patient has a lot of solids present that need to be treated quite differently than the patient with just stage 1 disease. Here, even stage 2 disease is quite different. The leg on the left is a cancer lymphedema following cancer, while the one on the right is congenital. How do we treat those? This is a patient that's a male patient. Male patients tend to be more difficult to treat, have slower recoveries, but we still can achieve excellent results if we take care of them in the proper way. And here's a patient who has actually a stage 1 lymphedema. It's actually fluid predominant, and this lymphedema is secondary to the morbid obesity that patient's experienced. So that patient needs therapy, not surgery. If the surgeries are not approached, I think, in what to me is the most optimal way, then, for example, microsurgery applied to a stage 2 patient would not produce a very good result, as in this patient here, where the leg is still big and there are continuing problems. The center patient has had a big resection at the medial aspect. There's a long scar going up and down her leg that didn't work. And here's one where there was a liposuction performed. And again, cosmetic liposuction does not work for patients with chronic lymphedema. The term liposuction is used, but it does not refer to cosmetic liposuction. I call it SAPL surgery, suction-assisted protein lipectomy, because the procedure is very, very different from cosmetic liposuction in many different ways. And again, we can have an outcome that's better consistently. So for me, these surgeries, SAPL surgery, which treats the solid component or more later stage disease, suction-assisted protein lipectomy, or the microsurgery and super microsurgery, VLNT and LVA surgeries, which are used to treat the phase 1 fluid component, need to be integrated into a complete system that involves lymphedema therapy as really the glue or the item that keeps everything together. Without the therapy done the proper way, these other surgical procedures won't work. This is a team-based effort. It's not just about a surgeon and the surgery. I couldn't do what I do without the wonderful people with whom I work: Sharon, Tao, Jerica, Julie, other Julie also. And clinically, if we didn't have a lot of people really working hard and taking care of the patients very closely, we wouldn't be able to achieve the results that we do. So here's a brief touch-up on the process as I see it. This is a simplification of the very complicated lymphedema disease process. As a refresher, if the lymphatic drainage is impaired, the lymphatic fluid itself builds up, causing stage 1 disease. That fluid that builds up is extremely toxic and inflammatory and causes surrounding tissues to be damaged. And that fluid is what drives the progression of lymphedema and the lymphedema disease process. Eventually, permanent solids and proteins build up in addition that can no longer be treated with just conservative care. That's called a stage 2, not reducible lymphedema. Stage 1 disease can be treated with conservative treatment, compression, and microsurgery. Stage 2 requires a SAPL surgery to treat the solids that build up afterwards. Again, the therapy is often in the surgical, I think, lectures underappreciated. And so I really want to highlight that right here, that the therapy is absolutely critical to achieving excellent results. Now, one way to separate out fluid versus solid, or stage 1 from stage 2 disease, is to perform a pitting test. This is where we apply pressure with the thumb for at least 1 minute or more and see if there's an impression. So this patient has a deep impression. She has a stage 1 or fluid predominant disease in the hand. However, further up in the forearm, the same compression makes very little dent. So she has a very solid predominant stage 2 disease up higher. Lymphedema therapy, again, is critical. Every patient needs to have therapy at the beginning for both stage 1 and stage 2. We want to reduce that fluid component as much as possible, and perhaps even avoid surgery with that if we can. Once that therapy is in place, we can arrest and prevent further progression of the disease with proper therapy and proper compression garment treatment. Pumps are also effective for some patients, and this therapy must be maximized before that surgical treatment can be considered. And those patients then can also be, their conditioning be used as a baseline after therapy to determine which surgery is required and how well we do with the surgery. Some patients will fool you. This is the patient I mentioned before. He has lymphedema secondary to morbid obesity. Now, believe it or not, this is all fluid predominant. These are photos sent from a wonderful colleague, and she's a therapist, and she was able to bandage and compress this patient down to remove all those excess fluids. The skin, because of the inflammation from the lymphedema, shrink wraps down and goes down without excess folds. And this patient does not need surgery. Now, he's also morbidly obese, and morbidly obese patients do not do well with surgery and are not really candidates for lymphedema surgery initially. They actually need to lose weight first to decrease the surgical risk and also decrease that additional inflammation and lymphatic burden so that our other lymphedema procedures can work. Patients who are morbidly obese are at much increased risk for any type of surgery other than lymphedema surgery as well. Here's an example of a patient who is, again, a tricky patient. She had a stage 2 disease, and so she needs to be treated with a volume reduction with the sample surgery to get her back down to that stage 1 issue. So this was congenital. She's had it for 46 years and had a previously unsuccessful resection procedure that left the scar up and down the inside of her leg with almost 5,000 cc's of volume excess. What's 5,000 cc's? Well, 2,000 cc's is a 2-liter soda bottle that you might buy at the convenience store, the very big one. So this is 2.5 of those excess. So this is 6 months after surgery. And again, now that the volume is down, the inflammation has gone down, she feels better. She can move and bend her leg better. She was able to get on a diet, get back to exercising, and then started to lose weight with the other side too. And so she continued to improve, and these are results that we can see with our patients, and we feel like we can achieve consistently. These are photos that she sent to us wearing the same clothing before and after. The procedure is, again, very different than cosmetic liposuction. It's not what I would consider liposuction. We use a tourniquet. It's 4 or more hours typically. The cannula, we're taking a leg. So the lower leg's been treated, the upper leg, the thigh here, from a pre-op diameter of about this much, and we're going down to that much. So it's a big change and a big improvement that the patients see, but there's a tremendous amount of care that goes into taking care of them before and afterwards. The volumes we get are consistently high. For arms, almost 1 liter. For legs, approaching 4 liters. And the results are consistent and long lasting. Again, in the operating room, we apply bandaging directly to get that patient down because their lymphatic drainage system is impaired and they cannot drain that surgical swelling that occurs. If we don't do this or place a very specific flat knit custom garment directly on the patient after surgery, they will not heal properly. This is a very specific type of bandaging. Those are not ACE reps. Those are short stretch bandages that need to be used to take care of the patient. The skin itself actually shrinks down. There's so much inflammation in a lymphedema patient that we find that the skin basically shrink wraps in about 99% of the patients, and no skin resection is needed, at least in my hands. Here, legs do the same, and they come down very consistently. And here, this is a case of a patient that did have some skin that needed to be resected because she actually had a stage 3 lymphedema. The skin was so thick, it was multiple centimeters thick and inflamed, and there's no real spot where the skin stopped and the inflammation started underneath. And so because she has this cuffing in her leg, we did have to perform some resection for her with an excellent result afterwards. Here's an example. So the patients also need to be selected properly for best results. A stage 2 patient with solids that are present, again, will not be able to be reduced with the microsurgery. So here the patient had microsurgery performed elsewhere. She had a solid predominant problem, which was present beforehand also, and she felt better had some improvement, but overall the continued inflammation that's present will cause and may cause continued damage to those repairs that are performed. So here are the repairs that were done previously. What we did is we applied the SAPL surgery, removed almost 6 liters of aspirate, and got her down to wearing normal clothes and improved compression. Finally, a 2-phase method for lymphedema surgery. What we can do is we can actually take a patient with chronic disease, downstage them with the SAPL surgery, normalize the size of their arm or leg, allow them to heal, usually a year or more, and then we can go ahead and reconstruct the lymphatic system when that system has recovered to the best extent possible. We can find better connections for LVAs. We can find better veins and arteries to plug into for our VLNT, and they have long-term results because that inflammation has been treated already. Here's an example of a patient, phase 1 SAPL surgery, phase 2 VLNT. Again, she's had lymphedema for a long time after breast cancer. After the phase 1 SAPL surgery, her arm goes down. This is a very typical result. She's still wearing the compression, as you can see there. Performed a lymph node transfer up to the armpit, and this is how she looks afterwards. And this is a comparison to before. Again, we can notice that she's not wearing the compression garment during the day. So the first surgery brought her size down. The second surgery keeps her down, but she doesn't have to wear the garment during the day, and that's a massive improvement for this patient. Again, this is surgery site hides under the armpit. Again, here too, this is a patient that had a stage 2 disease, previous LVA, isn't going to work for a stage 2 problem, isn't going to address the solids. So we were able to bring her down and then with the SAPL surgery, perform a stage 2nd phase and really decrease the type of garment she needed and the amount of garment use that she needed. And so she sent us some photos. I just saw her 2 weeks ago, and this is before and after, and it's really been life-changing. And we love to see these photos that the patients do send us. We've written this up and published these results as well. Again, I'll reiterate one more time, therapy is absolutely key. The surgeon needs to have a good relationship with the lymphedema therapist before and after surgery. We have a plan beforehand going in, so the treatment can happen beforehand and afterwards as needed. It is absolutely not effective for the surgeon to never have a conversation with the therapist and maybe send a sheet of paper out to an unknowing therapist to hope that they take care of the patient. That's not going to work. The therapy integration is absolutely critical, and we really do believe in this. Thank you very much.